Good afternoon, folks. This is Victor Gravio here at ABH. With me are Lydia Conley and Megan Thompson, and we're glad you could join us today for our healthcare reform and MassHealth systems transformation presentation. We know it's a beautiful summer day out there, so hopefully some of you are outside at the beach as you're listening in and following along. This is the second presentation we've done. We did our first webinar 2 weeks ago on with the same materials. So we're glad you could join us today. If there are folks that participated in the first webinar, welcome back. We have some housekeeping around the logistics of the webinar, so I'm going to turn it over to Megan, and then Megan is going to turn it over to Lydia to get us started. Megan?
Great. Thank you, Vic. Hello, everyone. Before we get started, I'd like to just go over a few housekeeping items so that you know how to participate fully in today's webinar. So we've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer in the upper right corner. You can either listen using your computer's speaker system or by joining over the phone. You can switch audio by selecting telephone or computer in the audio pane at any time. You will have the opportunity to submit text questions to Lydia by typing your questions into the questions pane of the control panel. You may send in questions at any time during the presentation, and we will be stopping throughout the presentation to address questions throughout. If we are unable to answer your questions in that time we take, we'll be sure to address them at the end if we have time. You will also see in your control panel a handouts pane. You can click and download these handouts at any time during the presentation. Lydia will refer to these throughout her presentation, and we've also included a copy of the slides in case you want to print those and take notes on the slides themselves. If you have any technical difficulties during the webinar, please call 877-582-7011 for immediate support. And now I'd like to turn it over to Lydia.
Thank you, Megan. So today we'll be talking about healthcare reform and systems transformation. This webinar is going to give participants a high-level overview of state-level healthcare reform and systems transformation. It will have a significant focus on planned MassHealth, which is Massachusetts Medicaid program, systems transformation. ABH intends to host additional webinars as we approach go-live dates for new MassHealth plan options. And some of the specific topics that we're going to cover today, so you can plan ahead, are we're going to cover some key terms that relate to MassHealth systems transformation. We're going to discuss the goals and drivers for systems transformation, as well as the approach and pathways that the Baker administration is taking. We're going to talk about key components of the systems transformation, which include accountable care organizations, community partners, community service agencies, and managed care organizations. We're going to touch a little bit on the future of MassHealth from a payment, a provider, and a member perspective. We're going to touch briefly on substance use disorder expansion, and then we'll review the timeline for all of these changes. So key terms that we'll be talking about throughout this presentation. Accountable Care Organization, or ACO. An ACO is a network of physicians, hospitals, and other healthcare providers working together to provide integrated healthcare for their patients with the goals of improving health and containing costs. ACOs enter into population-based payment models with payers, and they're held financially accountable for care, quality, and cost. Behavioral Health Community Partner, or BHCP. This is a community-based entity which contracts with the Massachusetts Executive Office of Health and Human Services and partners with MassHealth contracted accountable care organizations and managed care organizations, providers, social service organizations, and community resources to support MassHealth members with complex behavioral health needs. Delivery System Reform Incentive Payments, DSRIP program. This is a program of time-limited federal investments to support the transition of healthcare providers to value-based care. Managed Behavioral Health Organization, or MBHO. This is a specialty entity that manages and/or provides covered behavioral health services. Managed Care Organization. This is an entity that provides and/or arranges for covered services under a capitated payment arrangement that's licensed and accredited by the Massachusetts Division of Insurance as a health maintenance organization. Section 1115 demonstration, sometimes called a waiver. The Social Security Act allows states to seek permission from the federal government to waive certain provisions of federal Medicaid law and receive flexibility to design and improve programs to meet unique state needs. In November of last year, the federal government approved Massachusetts' request to amend and extend its existing Section 1115 waiver for 5 years and to support system transformation. Social determinants of health, sometimes called SDH or SDOH. These are the structural determinants and conditions in which people are born, grow, love, work, and age. These include factors like education, housing status, employment, socioeconomic status, physical environment, and access to health care. MassHealth Systems Transformation Goals and Drivers. So if you look at this slide on the right-hand side, and it is a little bit small, you can see that MassHealth expenditure growth has significantly outpaced revenue growth for the Commonwealth. At this point in time, MassHealth is about 40% of the state budget, and there is a perception that it is crowding out other investment areas in which the Commonwealth would like to invest, like infrastructure, public education, things like that. MassHealth over the past year or two has brought down growth through program integrity efforts, operational and other efforts to control growth in the near term, but is looking for a way to ensure the long-term sustainability of the MassHealth program. And you can see from the bullet that is the #1 driver of MassHealth systems transformation, ensuring financial sustainability. The Baker administration is hoping to leverage this as an opportunity to improve population health and care coordination through payment reform and value-based payment models, to improve the integration of physical and behavioral health care, and to scale innovative approaches for populations receiving long-term services and supports. And the landscape for most of the MassHealth systems transformation is going to be managed care. So this slide is showing you the current MassHealth managed care landscape under the Section 1115 waiver. So it represents about 1.2 million of 1.9 million MassHealth members, and this is as of today. So the options for people who are MassHealth managed care eligible, which really means managed care mandatory, are working on the left-hand side of the slide. The primary care clinician plan is available to those members. There's about 414,000 of them today. They access their behavioral health benefits through the Massachusetts Behavioral Health Partnership. Then there are managed care organizations, which have about 833,000 members. In Massachusetts today, there are 6 of them. 5 of them utilize managed behavioral health organizations, such as Beacon Health Options, and then 1, Tufts Health Public Plans, manages its behavioral health internally. Each of these MCOs operates in 1 or more of 5 MassHealth regions: Northern, Greater Boston, Southern, Central, and Western. Moving forward, the regionality of MassHealth may change to some degree. So the approach for MassHealth systems transformation that the Baker administration envisions is to take us from a current state to a sustainable model. So today's state of healthcare, not necessarily limited to the MassHealth environment, is one that rewards volume that's really built to address emergency or short-term medical events. It's difficult for members to navigate the system. You may have multiple physicians or clinicians treating the same patient for the same condition, not necessarily talking to each other or even being aware of one another. There's limited transparency into quality and efficiency of care, and patient information is often stored in silos or paper medical records. As we move to a sustainable model, the Baker administration is hoping to reward outcomes and value, to have MassHealth members' health managed seamlessly across providers and over time, not on a visit-by-visit or episodic basis. Providers should really be acting as a team to ensure the coordination of the right services for that particular individual at the right time. Moving to a place where there's easier to understand quality and cost data available to consumers and to providers, and to make appropriate use of electronic health technology across care teams and with consumers. So how are we going to do this? The pathway, as we've stated, is the population of focus is the MassHealth managed care mandatory population. So these are folks under age 65 living in the community with no other insurance, including Medicare. It's about 1.2 million individuals. Today, about 833,000 of them are in MCOs, 414,000 are in the primary care clinician plan. There's a small exception to some of the systems reform around community partner care coordination services that will be available to dually eligible individuals enrolled in CBFS, and we'll touch a little bit on that later. The financial levers for this are delivery system reform incentive payments, or DSRIP programs, which is available under Section 1115 demonstration renewal. So in November, the Commonwealth secured approval for $1.8 billion of district funding over 5 years, with most of that funding front-loaded, and it will diminish over time until the end of 5 years when it evaporates. This will fund investments in infrastructure, capacity building, and care coordination. MassHealth is looking to shift the delivery system itself. It's looking to shift care delivery authority and financial risk, with different financial risk options available to provider-based entities. And there are two centerpieces to this. There are accountable care organizations called ACOs, and we'll talk about those in a minute, as well as community partners, and we will talk about those as well. So the key components, the accountable care organizations, ACOs, they're slated for $1.1 billion of that $1.8 billion investment of district funds. These are provider-led organizations that coordinate care. They have an enhanced role for primary care, and they're rewarded for value, which means improving total cost of care and outcomes, and not for volume. There are community partners. They're slated for $547 million of that $1.8 billion investment. These are provider-led, community-based entities that are focused on the member. They partner with accountable care organizations and with managed care organizations, other providers, social services, and community resources to support improved care delivery and member experience. There are two types of community providers. There's a behavioral health or a BH community provider, and long-term services and supports community partners, LTSS-CPs. There's also some funding for statewide investments. There's $188 million available over 5 years. This will fund things like healthcare workforce development and training, targeted technical assistance for providers, improved accommodations for individuals with disabilities or for whom English is a second language, and other priorities like emergency department boarding. And then finally, managed care organizations, which are very much part of today's landscape in Massachusetts, will remain, and they're expected to work with accountable care organization providers and community partners to improve care delivery and population health management. ACOs. So ACOs have responsibility for total cost of care for managed care spend. So today that means the physical and behavioral health expenditures, and over time long-term services and support spending will be phased in, as well as performance and quality measures. ACOs have an emphasis on primary care. They're responsible for team-based care management, coordinating care, managing care transitions, conducting comprehensive assessments, and developing person-centered care plans for their attributed members. They have dedicated flexible services funding to address social determinants of health. And the social determinants of health funding, those flexible services, can fund things like home and community-based services, certain medical-related goods and services, things like physical activity and nutrition supports, maybe gym memberships. They can address experience of violence support. They can assist with services to maintain safe and healthy living environments, and transition services for individuals leaving institutions. So now we're going to talk about a very core concept to the MassHealth systems transformation. This is primary care exclusivity. And the reason why this is important is because moving forward, when these health plans go live, MassHealth members are going to follow their primary care docs into new plan options. So what primary care exclusivity means is each ACO's primary care providers participate exclusively with that ACO, meaning that a member must join the ACO to receive primary care services from that provider. This also means that a member that chooses a primary care provider who is in an ACO will be assigned to that ACO. The exclusivity is practice or entity level. That's similar to how the primary care clinician plan works today. Primary care providers can still provide specialty services to eligible members outside of their ACO, but they can't have these members assigned to their primary care panels. This applies only with respect to MassHealth managed care eligible members. So primary care providers can still provide primary care to MassHealth fee-for-service members, including those who are dually eligible or those who are in other insurance products. The exclusivity requirement does not apply to specialties like behavioral health. The behavioral health providers have a wide range of contracting options moving forward, as they do today. There are 3 models of accountable care organizations that MassHealth is going to be contracting with. There's an accountable care partnership plan. It was formerly called a Model A. This is where a single ACO is partnered with a single MCO. Because there's a health plan involved, they're paid a prospective capitated rate for their attributed members. This is full insurance risk, the highest level of risk that you can assume. All enrolled members receive their primary care from that ACO's primary care providers. Members can see any providers in the plan's network, so for example, behavioral health providers. And unlike the managed care organizations today, they can serve a smaller geography than a MassHealth region. And that is certainly what the contracts appear to be shaping up to look like. MassHealth will be contracting with 13 accountable care partnership plans. The second model is a primary care accountable care organization, formerly called a Model B. This is an ACO that's contracting directly with MassHealth, so there's no health plan involved. They share savings or losses with MassHealth based on total cost of care and quality performance for their attributed members. All enrolled members receive primary care from that ACO's primary care providers, but aside from their primary care provider, members can see any provider in the MassHealth network, and for behavioral health, they can see anybody in the Massachusetts Behavioral Health Partnership Network, the MBHP network. And there are 3 primary care ACOs that MassHealth has contracted with. Finally, there is the MCO-administered ACO, formerly called a Model C. This is an ACO that contracts with 1 or more MCOs. This type of ACO is accountable to its MCOs through shared savings and losses and arrangements that MassHealth has to approve. Members enroll in the MCO and then either choose or get attributed to that ACO based on their selection of their primary care provider. And just as with MCOs today, the members can see any other provider in their MCO's network. And there is 1 MCO-administered ACO contracted. So right now we'll stop for some questions.
All right, so as a reminder, if you'd like to submit questions, you can do so by clicking the Questions tab on your control panel. And again, we'll be taking questions throughout the presentation, so feel free to submit them now or as they come up.
So the question we received, we had some feedback on sound cutting out for one individual. So the question that we have so far is, the individual is not able to hear what I said about why behavioral health doesn't have ACO restrictions. Would she please explain why during the Q&A sessions? So I did not explain why there is no restrictions for behavioral health providers. The premise of accountable care organizations is that the primary care provider is the hub for it, and in order to hold an accountable care organization accountable, to hold them accountable for whether they are effective or not, the primary care provider can't be affiliated with multiple ACOs because you would not know which ACO to attribute the success or failings of. So that is why the primary care provider needs to be exclusive. Other than that, specialists of all kinds, including behavioral health providers, there's no need for exclusivity. The next question is, how do you anticipate that the statewide DSRIP will be distributed? So we could talk about that a little bit further. The state was approved for 8 buckets of funding for statewide investments. Many of them focus, I believe 4 of them are focused on workforce development, and community-based behavioral health organizations will be eligible for those funds. The applications for the first round of that funding, so I think for the first 3 programs in that, focused on workforce development. Those will come out in November. There'll be a competitive application process from what we understand, and there'll be clarification about which types of providers will be eligible for that at that time. So the next question is, will providers be given a list of participant programs in order to make a decision on which category to support clients' decisions? I'm not sure I understand that question, so if the person who submitted it could restate that so we could try to better answer that. The next question is, can you match up the 3 types of ACO models with the names of the ACOs selected? Yes, that's covered on a future slide. Any information on what impact UMass not contracting will have? So what this individual is referring to is that University of Massachusetts Medical School has elected not to proceed with contracting with MassHealth as an ACO. We don't have any additional information on the impact of that right now. Let's see, then there's another question about there was a MassHealth Innovations presentation about the behavioral health workforce development. Oops, we lost that question, hold on. Initiatives plan with the Section 1115 DSRIP funds. There were supposed to be guidelines in August, but we haven't heard more. We have some slides we can present on the statewide investments, so we will cover those if we have time. Let's see. example, second category provides food. Oh, okay. So the question originally about which types of providers or which types of ACO providers there are and whether you want to proceed to make contracting decisions. I can attempt to answer that question as we get towards the end of the presentation, but maybe we should go through the entire presentation. I'll try to answer that. If we are contracted with the managed care organizations, will our payments be based on these contracts, or will new contracts be needed with ACOs? You will need to, our understanding is you will have to have new contracts with ACOs because the member assignment will work differently, the rates will work differently, they'll be developing new networks. Is participation in an ACO totally voluntary? If you're referring to the MassHealth member, you can opt out of an ACO by selecting a non-primary care provider that is not in an ACO. But if you followed your primary care provider, if you like your primary care provider, you have to do what your primary care provider has decided to do. Can you explain the three models again? If we have time, I will cover the three models again. Okay, so I think at this point we'll move on and we'll try to address some of these questions as the presentation moves forward. Systems transformation, behavioral health, and long-term services and supports community partners. So these are community-based entities to help MassHealth members with high behavioral health or complex long-term services and supports needs navigate care. The ACOs and MCOs are required to partner with community partners and vice versa. MassHealth's intention in creating these entities was to leverage expertise and capabilities of existing community-based organizations serving populations with behavioral health and or LTSS needs. And I shouldn't have said MassHealth created them, MassHealth is procuring them from existing experienced organizations. The intention is that the community partners will break down existing silos, deliver integrated care, and help address social determinants of health. The behavioral health community partners are going to deliver health home type support. So the Affordable Care Act created these care coordination entities or functions for folks with chronic medical conditions. The behavioral health community partners are very much modeled on that. The activities that they will carry out are outreach and active engagement, comprehensive assessment and person-centered treatment planning, care transitions, health and wellness coaching, connection to community and social and flexible services, care coordination and care management, and medication reconciliation. MassHealth is winding down their procurement process for the community partners. There were 22 behavioral health community partner bidders. It was a geographically based procurement based on the 5 MassHealth regions, but sub-region bidding was allowed. They're looking to procure approximately 4 behavioral health community partners per region and 2 to 3 LTSS community partners per region. That may vary in the final contracting. MassHealth is looking for the entities most capable of serving identified populations, so individuals with serious mental illness, substance use disorder, and LTSS needs. There were threshold criteria for community-based entities. One of the things that MassHealth was looking for was a capacity to serve a minimum panel size of 1,000 lives. They looked at things like existing infrastructure in terms of personnel, facilities, their IT systems. What did the collaborative working relationships look like with providers and other organizations in the areas in which the applicant was proposing to serve? Cultural and linguistic competence, and the willingness and ability to partner with multiple accountable care organizations and managed care organizations. MassHealth was looking really for deep expertise in behavioral health. They were looking for providers or consortiums of providers with experience and expertise supporting populations with serious mental illness, chronic substance use disorders, and co-occurring disorders. Applicants had to demonstrate either by themselves or in coalition experience in services in 4 categories of care. So delivery of community-based mental health services, so things like community-based flexible supports under DMH contract, ESP services, PACT, CSP, substance use disorder treatment, so ATS, medication-assisted treatment, outpatient mental health services, so day treatment, medication management, IOP, as well as integrated care management services, so experience with coordinating and managing care for MassHealth members or similar populations. So examples would include the One Care Health Home or the MBHP provider-based care management program. They were looking for existing MassHealth providers or providers that were contracted with MassHealth managed care entities, and applicants also had to demonstrate at least one clinical service contract with a state agency like DMH or the Bureau of Substance Abuse Services or the Department of Children and Families. In terms of accessing behavioral health community partner support, so how are MassHealth members eligible? There's two main pathways. So these are for adults with serious mental illness and or chronic substance use disorder. There's what MassHealth has called an analytic pathway. So this is folks that were identified via claims, but it's a diagnosis plus a utilization pattern or comorbidity or other factor like DMH involvement. So for example, you might have a schizophrenia diagnosis and had 3 inpatient visits in a 12-month period, and that would get you into the analytic pathway where you're deemed eligible for the service. MassHealth estimates that there's about 60,000 individuals who are eligible for the service, and there's funding to serve 35,000 of them at any particular time. MassHealth has said, and the contract should reflect that where a MassHealth member has a relationship to a behavioral health community partner, the member is going to be assigned to that behavioral health community partner. The member has freedom of choice to not participate in BHCP services or to select another BHCP in their region. There's also a qualitative or referral pathway that will flow through the accountable care organization or managed care organization. The process for that is to be determined, but basically MassHealth has recognized that there are going to be individuals that don't sort of tick off the boxes for the analytic pathway but could certainly benefit from community partner care coordination services, and there will be a pathway for them into service. If an individual has both behavioral health and long-term services and supports needs, that member is going to be offered behavioral health community partner supports as opposed to the LTSS community partner supports. For transition age youth, so members ages 18 to 20 with substance use disorder problems, EOHHS may refer that individual to a behavioral health community partner for support instead of through an existing community service agency. For children and youth, the existing infrastructure of the community service agency is going to be leveraged. There'll be nothing changing about that. The care coordination benefit will remain the intensive care coordination. The CSAs were eligible to respond to an RFR for district infrastructure dollars, but there are no additional district dollars for service payments. Intensive care coordination is currently a Medicaid state plan service, and unlike the community partner supports, where the funding for that will phase out at the end of 5 years, the intensive care coordination service benefit and dollars will continue after 5 years. So this slide is showing which populations are eligible for community partner support, so which types of MassHealth members. So looking at the slide, the green boxes, this is a managed care eligible population, so about 1.2 million MassHealth members. You can see that the individuals who are enrolled in accountable care partnership plans, that's the integrated ACO-MCO, individuals that are enrolled in the primary care ACOs, this is the ACO that contracts directly with MassHealth, and then individuals who are enrolled in MCOs, whether they're in an MCO-administered ACO or not. All of those folks are eligible for behavioral health community partner services if they meet the clinical criteria. There's funding to serve about 35,000 members, as we discussed previously. Unlike those managed care options, individuals who are enrolled in the primary care clinician plan, which is a managed care model, they will not be eligible for behavioral health community partner supports. The rationale for that is there's no accountable entity on the primary care side, and it would be unfair to have the community partner responsible for coordinating care when there's kind of no one to work with. The one exception to this is if we move over to the right-hand side of the slide are folks that are dually eligible for Medicare and Medicaid. So individuals that are in existing integrated care options like senior care options or OneCare, they do have their care coordinated through those programs. There still is a relatively large population that is accessing MassHealth on a fee-for-service basis. They are not eligible for community partner supports with the exception of individuals who are enrolled in Department of Mental Health community-based flexible supports. Those individuals, about 1/3 of them are actually managed care mandatory, and so they would already be able to access behavioral health community partner supports. There's about 8,000 that are dually eligible that are receiving MassHealth benefits on a fee-for-service basis. They will also be eligible for behavioral health community partner supports. The behavioral health and LTSS community partners, so again, they're slated for about $547 million of district funding over 5 years. For the behavioral health community partners, there is dedicated funding for infrastructure. So this is a capitated payment. It starts off at $35 per member per month and phases down to $5 per member per month at the end of 5 years. This funds things like IT, staffing up for the program, things like that. There are then dedicated funds for the community partner care coordination services, so to fund those health home-like activities. That's also capitated payment. For the bulk of the population, that's $180 per member per month, but for individuals who are enrolled in community-based flexible supports, that rate is $250 per member per month. There's a potential for some small quality bonuses. The metrics for that are to be determined. All of these funding streams have incremental portions that are at risk tied to performance. And what at-risk means is that there's actually a payment withhold until the provider is able to demonstrate performance in a way we'll talk about in a minute. So in year 1, there's no payment withhold, but by the end of year 5, 20% of those payments are withheld from the community partner until the performance metrics can be assessed. The accountable care organizations and the Commonwealth are likewise held at risk, also tied to performance metrics. Unlike what has happened in district in other states, MassHealth is paying the community partner directly for 5 years. After 5 years, the assumption is that the community partners have demonstrated a return on investment for their service and will be able to negotiate with accountable care organizations and managed care organizations for their sustainability. So the behavioral health community partner performance measures, these are the domains that are that the at-risk funding is tied to. They're weighted domains. Each behavioral health community partner will have a district accountability score, and it will cover things like prevention and wellness, so things about like, did the annual wellness visit occur, chronic disease management, how are we managing diabetes admissions. There are some behavioral health specific measures, follow-up after behavioral health hospitalization. There's a member experience measure that will be based on a survey. There'll be what MassHealth is calling integration measures about, did those flexible services dollars get utilized? Avoidable utilization is a category. It will look at things like all-cause readmissions and preventable emergency department visits. And then finally, most heavily weighted at this point is engagement. This is whether the behavioral health community partner member or enrollee had an assessment and a care plan done within 90 days, which is a contracting standard. So now we're going to talk a little bit. If you were on the first version of this webinar, we got some feedback on an earlier version of this slide, so we redid it based on your feedback, and hopefully it's somewhat more clear. So this is attempting to show how the ACO, the behavioral health community partner, and then other providers will function together in terms of a care relationship. So we're not talking about payment. Community partners have no role in payments, period. So we're going to talk about care relationships. So on the left-hand side of the slide, this is most ACO members. So you have the accountable care organization in green on top. So the ACOs are charged with coordinating care, so that means primary care, behavioral health, and other specialty care, and arranging for supports for the overwhelming majority of their members. So MassHealth is estimating there's going to be about 850,000 MassHealth members enrolled in ACOs in 2018. So for the overwhelming majority of them, the ACO will be responsible for the care coordination. The ACO will be working with behavioral health providers and other specialists to get those individuals the services that they need, the right services at the right time. In addition, they'll be working with social services agencies that are able to offer support like housing stabilization and nutrition assistance. Again, they have those flexible services funds to help address social determinants of health, and they can work social service agencies on that. So the left-hand side of the slide is sort of the general ACO population. The right side of the slide these are the ACO members with high behavioral health needs. So it's a subset of the ACO membership. It's the members that have complex behavioral health needs. So as we stated earlier, there's about 60,000 folks who are eligible. There are funds to support about 35,000 of them at any particular time. In this model, it's the behavioral health community partner that's going to coordinate the medical, the behavioral health, and LTSS care and supports. And they will also assist with the social determinants of health support, so connections to social service agencies. So you can see at the top of the slide, there's the accountable care organization, but you also have the behavioral health community partner working with social services agencies. The behavioral health community partner is helping to work with other behavioral health providers and other specialists to coordinate care, but there also is because this is a team-based model, the behavioral health providers and the other specialists are working with the accountable care organization. All of this should be functioning as a team. Moving on, so for children and CSAs, so the community service agencies, the CSAs, they're going to continue to deliver services as they do today. The medical necessity criteria and service specs are going to remain unchanged. The CSAs are going to be paid for services just as they are today. The CSAs are eligible to respond, were eligible to respond to an RFR that has closed for district infrastructure and capacity funding. The CSAs that did apply, they could respond in domains like workforce development, operational infrastructure, and technology. Their applications had to specify how they would improve integration with managed care organizations, ACOs, and primary care providers, particularly pediatric practices. They have to partner with ACOs and MCOs in the service area if they wanted to access those dollars, and they would also be accountable for quality measures around prevention and wellness, behavioral health, member experience, avoidable utilization, et cetera. So now we'll stop for a minute for some questions, and it looks like we have a few.
Okay, so again, just a reminder, you can submit questions through the questions pane in your control panel.
Okay, so the first question is, what does emergency department boarding mean? So I think this question is related to statewide investments and what MassHealth is thinking about doing with this. So this, again, is individuals often with behavioral health disorders that are basically stuck in emergency departments waiting for appropriate placement. The MassHealth hasn't really released a whole lot of detail on what they'll be using statewide investments for to support for the, to address emergency department boarding. Some of the things they were talking about are supporting sort of an event notification system specifically focused on emergency departments and maybe some other things like that, but there's not a whole lot of detail on that one at this point in time. The next question is, how will these changes be explained to members? How can CBHI providers help members learn what they need to know and ignore what might be confusing? That is an excellent question. So we are planning on having a webinar as we get closer to go live date on all of this. Like, how is MassHealth going to be messaging members? How can, exactly to that question, like how can you mitigate confusion amongst the individuals that you're helping? The general plan is that MassHealth they're going to message everybody in their managed care caseload. So every child, every head of household is going to get a letter explaining to them what's going to be happening to them. The heads of household will get a MassHealth member booklet. But yes, we'll have a webinar as it gets a little bit closer to help figure that out, or to help you figure that out as best as that's possible. The next question is, if a non-participant primary care provider is selected, our medical costs are covered. I'm not sure I understand that question either. So if you could please restate that question, we'll try to answer that. The next question is, can a member select a behavioral health provider that is not a CP? Absolutely. It's not intended to disrupt treating relationships. Community partners are, they're intended to be a care coordination function. So if the MassHealth member has a therapist that they love at a non-CP provider, that's completely fine. They can continue that relationship. Okay, the next question, what if there are youth with extensive care coordination needs, but they do not meet the medical necessity criteria for ICC, for example, substance use disorder? How are those youth served?
So this is Vic. So I think and Lydia, correct me if I'm wrong, if the youth are under 18, I think they have to meet the criteria for ICC, which is SED. I believe if they're 18 or older, though, if they have an SUD, they do have the option of having care coordinated by a behavioral health CP.
Yeah. I mean, one thing providers could think about is that as you develop relationships with accountable care organizations, is proposing to develop something like an ICC model that would fit kids that don't quite meet that level of care criteria, but could benefit from that care coordination service. But there's no policy answer to that at this point in time. Please explain again why PCC members are not eligible for the behavioral health community partner support. So MassHealth's rationale on this one is that there's no accountable care entity, so the behavioral health community partner will be coordinating care but won't have a primary care partner to be working with them. So that's essentially the rationale. They didn't think it would be fair for the community partner to be at risk for those individuals when there wasn't necessarily anybody with whom they could partner on that side. MassHealth has indicated they might be open to revisiting that down the road, but that's not a day one undertaking. How will children that are involved in CBHI services, IHT, et cetera, that are receiving treatment at a non-BHCP agencies be affected? They're not at all. They continue to have their care coordinate. They continue to get their ICT through a CSA or other services through the provider of their choice. Yeah, it really is. The Commonwealth is looking not to avoid disruption of CBHI in any way. It's business as usual. The next question is, how does this transformation impact programs that are paid based on bed days? So at this point, it doesn't have any bearing on that whatsoever. For the most part, services will continue to be paid, at least in year one, on a fee-for-service or your current sort of rate methodology basis. There should be no disruption to that. Will the CSA staff have to be trained in medical pieces as well to help educate the families with high medical needs in addition to mental health needs? I believe it's currently a performance specification that MassHealth has reinforced with ABH and the providers. For those that applied for the district infrastructure dollars, I don't know to what extent they propose to having better connections with primary and pediatric practices, but we would assume that area would be well covered by applicants. One more. We have time for one more question right now. Would you please explain more fully what the $185 per member per month payment is on page 21? So the $180 per member per month, that covers the care coordination service that the community partner is delivering. So for all of their enrollees, they'll get $180 per member per month, provided that they deliver, I believe it's at least one qualifying activity within the month. So it could be outreach to the member, it could be all of those qualifying activities are specified in the contract, but that's what it covers. Okay, so we're going to move on, but we do have a lot more questions, so we'll try to get to them. The managed care organization procurement. So again, managed care organizations have been a long-standing feature of the Massachusetts landscape for Medicaid. They're going to have an important role in ACO implementation. MCOs remain the insurer, pay claims, and work with ACOs to improve care delivery and support care integration, both for their own members and where they're partnered with accountable care partnership plans, so that's the integrated ACO-MCO, and for the MCO-administered ACOs. They're similarly intended to support ACOs in building capacity, including providing population health management analytics. And some of the criteria that MassHealth is looking for as they re-procure the managed care organizations, which is that the RFR for that is closed, and we expect announcements in the very near future, are very clear track record of high-quality member experience, strong financial performance, high-quality encounter and performance data, the ability to manage MCO-administered ACOs, and then finally the ability and capacity to assume responsibility for long-term services and supports in the outer years of the contract. And just some of the goals and highlights that MassHealth pointed out for their procurement. EOHHS has stated an intention to contract with no more than 3 bidders per region. That is a change. In some regions you have 5 or 6 managed care organizations right now. That would be, if MassHealth holds to that, there'll be fewer MCOs. And they've also stated a preference for statewide bidders. So there is at least one regional MCO right now, so what that means, what that preference means for contracting, we're not quite sure yet. So the MCO bidders are all of the current players. There aren't any new ones. So it's Boston Medical Center Health Net Plan. They currently use a managed behavioral health organization, Beacon Health Options, as does Fallon Community Health Plan and Neighborhood Health Plan. Celtic Care Health also put in a bid. Their current managed behavioral health organization is Simpatico. Health New England put in a bid. They're using the Massachusetts Behavioral Health Partnership. And Tufts Health Public Plans bid to be a managed care organization as well, and they manage their behavioral health benefit internally. So we'll stop to answer some questions, some of our many questions here. Are there instances where a community partner is also a community service agency? We would anticipate that's the case. We need to wait to see who the awardees are for the behavioral health community partners, but that's highly likely there will be such instances. If the ACOs are responsible for coordinating care for all of their patients, how do the ACOs pick which BH providers to refer to if providers are exclusive to the ACO. So if you're an accountable, the answer will change to some extent depending on what kind of accountable care organization you are. So if you're an accountable care partnership plan, the behavioral health provider has to be in the network. The person still has freedom of choice within that network. The ACO could potentially develop preferred referral relationships, just like they could today under a managed care relationship. For the Model Bs, which is the primary care ACO, the MDHP network is the network, and it's not really clear whether those ACOs will have much say in how in the choices, in how those choices get made. And then the Model C, the MCO administered ACO, the Model C, they're basically like a primary, they're almost like a very large group practice within an MCO network. So it really functions like the managed care organizations do today. As long as you're part of the behavioral health provider is part of the network, they are available to the MassHealth member. Are there program/agency productivity standards? I'm not sure. For those, if this is relative to community partners, I know that the applicants that applied for that were sort of looking at the per member per month and trying to figure out, they were trying to answer that question in terms of the staffing patterns they were proposing, but there's no real productivity standards that I'm aware of that MassHealth is thinking of for community partners, and there's no changes to outpatient services or anything relative to this initiative. Is it reasonable that there are only funds available for 35,000 of the 60 to 65,000 eligible members, meaning will people be declined services and put on a waiting list if there are no slots available? Theoretically, that's possible. Based on our members' experience with other care coordination models like CSA and OneCare, we don't think that there's any danger of hitting that $35,000 member participation mark, but theoretically that is a possibility. And perhaps within a particular community partner, they might hit their sort of ability to serve, but not likely. Are the ACO members with high-risk needs the same as the current CBFS population? So the CBFS population is eligible for the community partner service. There are people who aren't probably CBFS enrollees, or there certainly are people who aren't CBFS enrollees that also meet that criteria, again, based on MassHealth claims, diagnosis plus some utilization pattern. Are non-participant provider expenses 100% covered, or will participants have a cost impact? If you're a provider, and we'll look at a provider perspective in a little bit, as long as you're part of the particular network, so just like today where you're checking EVs to figure out whether, what managed care plan the individual has, and, if you're part of that network, then you can serve them. It will work quite similarly. Will the MassHealth eligibility system be used to assign members to ACOs? Will the ACO information be shown on POSC? So what MassHealth will be doing is the MassHealth member will be following their primary care doc into their plan option. So that's how that's going to work. The information will eventually appear in POSC and EVs. Our understanding, though, is that providers will not be able to see what plan the individual has until this goes live. So you would not actually know what plan they're in until March 1st of 2018. It does not appear likely that that's going to change. It does not sound like that's a function. EVs is not able to capture future eligibility, but that is something we're concerned about. And we will cover that in a future webinar. How many EHR software platforms is an individual CP expected to be on to engage on? So MassHealth has said that the ACOs are not going to be will not be allowed to mandate a particular EHR or care coordination platform, period. Can you please speak about qualitative measures of patient progress related to individuals who deal with chronic mental illness? These individuals often seek services to maintain stability as opposed to making significant measurable improvements over time. All right, so this question I think we'll take offline, and we can get you some information on that. I have more information on the quality measures. I take your point. Most of the measures that MassHealth is holding the community partners accountable to are HEDIS-like measures that aren't really getting into sort of self-reported functioning, those types of things. It really is avoidable utilization, those types of things. I mean, there will be a survey component that will address the members' self-reported, how they feel they're doing, but that's very much to be determined. Are the MCOs changing? We will know the answer to that when MassHealth announces the results of the procurement in the very immediate future. There won't be any new ones, we can say that. The bidders that came in are the same 6 entities that are the current managed care organizations in Massachusetts today. Is the estimate of 850,000 ACO members only for the 17 ACOs that are going forward, or does it include the membership that would have been in the Tufts UMass Memorial? That includes only the 17 ACOs that are going forward. The previous estimate had been about like 900,000, I think. So they did reduce that to reflect UMass not participating. Okay, so we're done with questions now, and I will proceed. So now we're going to briefly talk about the future of MassHealth managed care. This is kind of like a day one perspective. So we're going to talk about it from a payment perspective, from a provider perspective, and then a member perspective. So this is the word about rates. So we have behavioral health rates. So what MassHealth is doing is they're adopting a fee schedule equivalent for behavioral health services for the accountable care organizations and managed care organizations. So this is nothing to do with community partners. This is services, traditional psychotherapy, med management, whatever. The fee schedule is going to function as a rate floor for identified behavioral health services. So what this means is that providers can negotiate with payers for rates above the floor, as well as for rates to deliver services not on the fee schedule. So for example, PACT is not a covered benefit under the MassHealth Managed Care Program right now. A provider could theoretically approach an ACO and offer to deliver that service and negotiate a rate. And then likewise, they can negotiate for rates above the floors. Our understanding about those rates is that they will be substantially similar, if not identical, to the rates paid by the Massachusetts Behavioral Health Partnership today, which for most providers would reflect a slight increase. These new provider rates, however, they're not going to go into effect before the new MCO capitation rates go into effect, which is currently scheduled for March 1st of 2018. So it's a little bit down the road. So that's the rate piece. Now, just to level set again, so we're going to talk about payment relationships right now. This looks substantially similar to a slide in the beginning. So this is the current landscape for payment relationships. On the left-hand side of the slide, there's the PCC plan. Those members access their benefits, their behavioral health benefits through MBHP. That's where the payment relationship is today with providers. The network contracting authorization, all of that happens through MBHP. Then you have the managed care organizations. 5 of them utilize managed behavioral health organizations, and that is with whom the behavioral health provider is interacting today to become part of the network, to negotiate rates, all of that. And then 1 of them does their behavioral health in-house, and so providers negotiate with, in this instance, it's Tufts Health Public Plans, negotiates with Tufts to become part of their network, to which services they're going to deliver, what those rates are. That's today's landscape. We're going to move forward. The next slide is going to talk about ACO potential payment relationships. It's going to zoom in, and then we're going to zoom back out to the entire managed care landscape. So this is Future State 2018, so these are just MassHealth members attributed to an ACO. So there's still the PCC world outside of this, as well as managed care organizations. So again, members attributed to an ACO, these plan types, there's about 850,000 of them. So what are the payment relationships going to look like relative to delivering therapy services to those individuals or other traditional behavioral health services? So on the left-hand side of the slide, we have the accountable care partnership plans, the former Model A's. These are the integrated ACOs, MCOs. BMC came in with 4 ACO partners. Fallon came in with 3. Health New England came in with 1. NHP came in with 1. And Tufts ultimately, Tufts and 4 ACO partners came in together. So what providers are going to be doing, what makes this a little bit complicated is they're proposing to serve different service areas. So we need some clarification on that. But providers would be working for those that utilize a managed behavioral health organization. And our understanding is all of those that do today will be doing so when they go live in March. So BMC HealthNet, Fallon, Health New England, and NHP, all of whom carve out their behavioral health benefit management, you would be working with the managed behavioral health organization. So, for example, Beacon, to become or to stay part of their network, to work out what services you're going to deliver and to negotiate rates. So again, there'll be rate floors, but you have the capacity to negotiate rates above that as well as to negotiate for other services. And then in the instance of the Tufts ACOs, or the ACOs that are partnered with Tufts in these accountable care partnership plans, you'd be having separate contracts with all of those entities, but it's the same general premise. You'd be working to be part of the network, to negotiate rates, to have your services authorized. So that's what that's going to look like under the Model A, the Accountable Care Partnership Plan. Moving to the center of the slide, this is the primary care ACO. This is the Model B. This is the ACO entity that contracts directly with MassHealth, and there is no health plan. So in terms of sort of your straightforward behavioral health service delivery, MBHP is really who you're talking to. So you're continuing to just be part of their network or to seek to become part of their network. They're authorizing services and working with you on rates and contracts, those types of things. You do not necessarily actually have a relationship with that primary care ACO. It doesn't mean that you couldn't approach an ACO for either they could pay for particular slots for their members, for priority slots, or they could pay for enhanced slots beyond what MBHP would pay for, those types of arrangements. But there isn't necessarily a payment relationship with the ACO in that instance. And then finally, MCO administered ACO, the Model C. So there's one of those basically what's happening there is you're continuing to work not with the ACO necessarily, but with the managed care organization with whom that ACO partners, or managed care organizations plural. So you might have an MCO that uses a managed behavioral health organization like Beacon. So you're working with Beacon to be part of the network there, or you might have one like Tufts that manages to be in-house and you work directly with the plan. So those are the payment relationships for members attributed to an ACO. You'll note that the community partners aren't represented on this page because they have nothing to do with payment relationships. So just to be clear, community partners aren't authorizing services or sort of controlling access to other community providers. Moving to the next slide, so the left-hand side of the slide is what we just covered. Those are the payment relationships for the accountable care organizations. On the right-hand side of the slide, these are the remaining members that aren't attributed to an ACO. So you have the primary care clinician plan. You're working with MBHP to be part of the network and to get your services authorized and paid. Then you're going to have whatever MCOs that MassHealth ultimately contracts with. So based on what we've seen from the bids, there will certainly be MCOs that utilize a managed behavioral health organization. So if it were for one of the MCOs that use Beacon, same thing. You'd be working with Beacon to be part of the network, negotiate rates, have your services authorized and paid. And Tufts was a bidder, so if they select Tufts and they do their behavioral health in-house, same thing. You're talking to Tufts about being part of their network, remaining part of their network, and negotiating rates, all of that. Again, community partners not on this slide because they don't have a payment relationship. So I'm going to stop here for some questions.
All right, and if you have any questions, we'll take a couple of minutes for you to submit those. It doesn't look like we've received any so far, so do ask your questions now, and we'll give it a minute or so just to see if any come in.
So the question is, where does OneCare fit in? So OneCare, we know that they're looking to re-procure that. It's not going away. MassHealth has stated that they're intending to grow that program, but that's outside of this initiative. Yep, it's a dually eligible population that's outside of this initiative. And CBFS members that will still be an option to people who are CBFS enrollees. Will current MCO contracts with providers be renegotiated? Yes, our understanding is that you're going to have to do that. And it's probably a good time for you to look at that. And again, there'll be rate floors, but you want to pay very close attention to what the MCOs and ACOs put forward to you. To the extent that you have rates that are currently negotiated above those floors, that's something you want to be very cognizant of if they're proposing to lower them to the floors, because we have seen that. Which MCO is working with Leahy? Leahy will have to partner with all of the MCOs in their service area, so we have to wait to see which MCOs get selected to know the answer to that for sure. Okay. All right. All right. We're going to move on. So this is the primary care provider perspective on primary care exclusivity. So this is, I'm a primary care provider, and I want to figure out what my participation options are, so therefore which MassHealth managed care eligible members can I deliver primary care to. So if I'm a primary care provider and I choose not to participate in an ACO, which managed care members can I continue to serve? I need to contract with the PCC plan and or the MassHealth managed care organizations in order to have any of the MassHealth managed care members on my panel. So relatively straightforward, but I'm not seeing ACO members. I've joined an accountable care partnership plan. This is a Model A. This is the integrated ACO MCO. I'm one of their network providers. So, for example, I've joined BMC HealthNet and Boston ACO. I can serve a panel of MassHealth members who are all enrolled in my ACO. So again, in this instance, I'm part of Boston ACO. So that's who I'm seeing. I cannot have a PCP panel in any other MassHealth managed care product. So again, I'm seeing only Boston ACO members. I can't see PCC plan members anymore. I can't see members that belong to another MCO like Neighborhood Health Plan, and I can't see members that belong to another ACO like Steward. So those are my options. I'm much more limited. I've decided to join a primary care ACO, the Model B. This is the model that contracts directly with MassHealth. I'm a participating provider, so I'm part of the community care cooperative. Who can I see? So I'm serving a panel of MassHealth members in my ACO, in community care cooperative. I can't have a panel in any other MassHealth managed care product, so I can't see PCC plan members anymore. I can't see MCO members, so I'm not seeing Tufts plan members, and I can't see other ACO members. So I'm not seeing Boston ACO members or Steward members. Finally, I'm a doc that's in an MCO-administered ACO. This is the Model C. It contracts with one or more MCOs. I'm a participating primary care provider. My ACO is going to partner with one or more MCOs. In year one, this ACO has to partner with all MCOs in my geography. I'm going to be required to contract with those MCOs as a network primary care provider for their members. And all the MCOs members who are assigned to my panel will be considered part of my ACO's attributed population. So basically, I'm seeing managed care organization members, but that's it. From a non-primary care provider perspective, and we're just going to walk across the behavioral health provider one, who can I see? So if I'm a behavioral health provider, I want to continue to serve as many MassHealth members as possible, MassHealth managed care members. So for both the PCC plan and the primary care ACO, that Model B, I need to be an in-network provider for the Massachusetts Behavioral Health Partnership. This is basically what I need to do. If I want to continue to see MCO members, whether or not they're affiliated with that MCO-administered ACO, I need to either contract with each MCO like Tufts, or for the MCOs that have a managed behavioral health organization like Beacon, I need to be part of their network and negotiate rates with them. Same thing, I want to see, there's all these new accountable care partnership plans. I want to see those members. So what I need to do is contract with the partnership plan or that plan's managed behavioral health organization if they have one. So I want to see their enrollees. I need to negotiate a rate with them, ideally above the floor. So that's the non-PCP perspective. So now we're going to transition to the MassHealth member perspective, so you can see how this shakes out a little bit. So I'm a MassHealth member. So remember, I'm following my doc into whatever option they selected. So my doctor has joined an accountable care partnership plan. So who can I see? I like my primary care doc, so I can see my primary care doc in this accountable care partnership plan. Or if I decide I don't like my doc, I can switch to another primary care doc within that partnership plan's network, but I can't switch out of it. But I also have a therapist that I really love. So how do I make sure I get to see both? So I have to make sure that my therapist is in either the partnership plans network, or if it's using a managed behavioral health organization like Beacon or Simpatico, I have to make sure they're part of that network. So this has always been the case to some extent. I have to balance my relationship. So if my therapist isn't in the accountable care partnership plan, I have to decide whether I am prioritizing my primary care provider relationship over my therapist relationship or not. So I've decided I made a mistake. I went with the accountable care partnership plan, but I want to go back to seeing my therapist. When can I change my health plan? Well, unfortunately, for the MassHealth member, you can only change your plan during your plan selection period, which occurs once a year. So you do get locked into your plan option for a period of time with a 1-year almost open enrollment. So moving down the list, my doctor has joined a primary care ACO. So they've joined, let's say they've joined Partners ACO. So who can I see? I can see that my primary care providers I like right now, but if I want to switch to a different one, I can switch to anyone in the Partners network. I want to make sure that I can continue to see the therapist that I have a great relationship with. Well, I just need to make sure that therapist is part of the MBHP network. I've decided, though, that I've made a mistake or I'm not really happy with my option. When can I change my plan? Again, only during your plan selection period, which occurs once a year. My primary care doc has joined an MCO or an MCO-administered ACO. So who can I see? Well, I can see that primary care doc, or if I want to switch to a different primary care provider, I can see anyone in that MCO's network, regardless of the ACO status. In terms of my therapist, I want to make sure that I can see the therapist that I like. I just need to make sure that my provider's in my MCO's network, if it's something like a Tufts where they manage it internally, or if they use a managed behavioral health organization, I need to make sure that they're in that network. And as with the other plan options, I can only change my plan once a year during my plan selection period. Then finally, the primary care clinician plan option remains available to MassHealth managed care members. I can see my primary care doc, or I can switch to any primary care clinician in the PCC plan network. And then just like today, there's no changes about this at all. I just need to make sure my therapist is part of the MBHP network. And I can change my health plan at any time because MassHealth is encouraging people to enroll in MassHealth in managed care products. And then just finally, a quick word about SUD expansion. The Section 1115 amendment and extension did expand substance use disorder benefits. So MassHealth will be covering ASAM level 3.1, both fee-for-service members and those in managed care options. So that will be available to them. Providers are going to begin billing MBHP for services as early as January of 2018, and the MCOs will come on shortly thereafter, well, about a year thereafter. In terms of the time frame for all of these initiatives, so we won't spend a whole lot of time recapping. All of the RFRs have closed. The ACO contracts have been announced. We had a slide on that in the presentation, and I believe it's an attachment, the contracted ACOs. The MCO and community partner bidders have been publicized, and we expect those awardees to be announced imminently. There's a third-party administrator that's been brought on to sort of start facilitating the management of long-term services and supports. Now, being summer through the end of 2017, plan timeline steps include selecting the community partners. Again, they'll be announcing those imminently. Managed care organizations announced imminently. MassHealth will start ACO and MCO readiness reviews. The applications for statewide investments for some of the initial projects will be coming online right now. We understand that will probably be November. And then starting in winter of 2017 and spring 2018, MassHealth will begin noticing members. They'll begin the member assignment process to MCOs and ACOs. The enrollments in MCOs and ACOs will begin in March of 2018, and the community partners are scheduled for April of 2018. So we'll stop and take some questions.
All right, it looks like we have about 15 minutes or so for questions. So we have a few we've received, and we'll just see if we continue to take questions. We'll answer them for as long as we can.
Okay, so how does this affect billing MassHealth? So if you're talking in terms of behavioral health services, it's going to look a whole lot like it does today. So you'll bill the managed care organizations just like you do today. You'll bill MBHP for their primary care clinician plans, and there's no changes to the fee-for-service environment. We are still seeking to get clarification for the ACOs that are partnering with the managed care organizations, the integrated ACO, MCOs. We are assuming they're using the same claims platforms and all of that, but we do need to get confirmation on that. So there would potentially be some hiccups there if they choose not to do that for some reason. Can the behavioral health community partner negotiate with all three groups, or do they need to choose one approach? So I think that the question is relating to which type of accountable care organizations. The Behavioral Health Community Partner needs to work with all accountable care organizations in their service area. So there's no choice about that. It's a required relationship. If a provider is already in an MCO network, do they need to recontract with the MCOs after the system reform? Yes, because the MCOs are in the process of being reprocured right now. So there'll be new contracts. MassHealth will have new contracts with the MCOs, and you will have new contracts with those MCOs once they're selected. When do providers negotiate their rates, establish contracts with ACOs? That we're not clear on. We think it's probably going to depend upon which ACO and MCO is involved. We understand from at least one member that they received a potential contract or proposed contract recently. Some of the other plans don't seem at all ready to figure out network configuration or any of that.
Okay, and we're going to give it a few more minutes to see if anybody else has any final questions. While we're waiting for any questions to come in, I want to let you know that we will be sending out a copy of today's presentation and the handouts in an email following as soon as we log off here. And we will also be making a recording of this webinar available, which will include closed captioning.
Okay, so can you explain the 3 models again? Okay, I will do that. Where are we? So the question is, can you please explain the 3 models again? So there's the Accountable Care Partnership Plan, the Model A. This is a single accountable care organization that is partnered with a single MCO. Because of the MCO's involvement, that entity is paid a prospective capitated rate for their attributed members. So this is the highest level of financial risk. It's full insurance risk, unlike the other models, which have lesser degrees of risk. They're sharing risk more with MassHealth or with managed care organizations. All of the enrolled members receive primary care from that ACO's primary care providers. The MassHealth members can see any providers in the plan's network, so for example, behavioral health providers. So again, so for the example of if you're Boston ACO and BMC HealthNet, they're one of these entities. That MassHealth member can see any behavioral health provider that ends up in that entity's network. These entities can serve a smaller geography than a MassHealth region, so the contracts that came in with this were for a wide variety of regions. So some of these accountable care partnership plans basically propose statewide coverage, but others propose really relatively small geographies. And we're trying to figure out how we can make that more apparent to ABH members so you can figure out how to prioritize how you want to have relationships or prioritize your relationships with these entities. Then there's the primary care ACO. This is a Model B. This is an ACO that contracts directly with MassHealth. So this is Partners, Community Care Collaborative or Cooperative, which is 13 federally qualified health centers that have collaborated together, and Steward. So those entities are contracting directly with MassHealth. There is no health plan involved. So that ACO is sharing either savings or losses against total cost of care and quality performance with MassHealth. All of those enrolled members receive their primary care from the ACO's primary care network, essentially. But aside from their primary care network, members can see any provider in the MassHealth network for specialties besides BH, and for behavioral health, they can see anybody in the MBHP network. And then there's one MCO-administered ACO. This was Leahy. This is an ACO that contracts with one or more MCOs. In year one, it's with all of the MCOs in their region. The ACO is accountable to the MCOs for shared savings and losses. What happens there is the MassHealth member enrolls in an MCO and either chooses or gets attributed to an ACO based on who they picked for their primary care doc. But just like today with an MCO, the members can see any provider in their MCO's network. And then SUD gets, the question is the level 3.1, do they get residential only up to 90 days? My understanding about this is that that's what the MassHealth benefit will cover. BSAS will still be available. Can MassHealth mandate the use of NEHR? I suppose they could. That is not part of the current plan. They have repeatedly said that they will not in the ACO and community partner contracting requirements, they will not do that. They're not going to mandate the use of particular EHR or care coordination product. Follow-up question, how and when do providers establish new contracts with their existing MCOs? Well, first, we have to wait until the managed care organizations are selected. So that would be step one. And then it's just going to depend upon how ready they are and probably how operationally focused they are on ACOs versus their MCO book of business. So I think, unfortunately, the answer is just going to depend. Will member enrollees who are in a Model A plan be able to receive BH and SUD outside their region? Only if the provider is part of that Model A's network. So only if the behavioral health provider is part of the network for that Model A, the integrated ACO, MCO, the accountable care partnership plan. If you're not part of the network, they're not seeing you. Several MCOs and MBHs are telling us they will just amend our existing contracts to add products, the ACO, update rates and services, and add new required MassHealth contract language. They say there's no need to negotiate another agreement or to replace existing agreements. I mean, that's something for you to have internal considerations, and I'm happy to have a follow-up conversation with you about this. We've already signed an ACO amendment with one MCO. Does MassHealth really require the ACOs to negotiate all new contracts with BH providers? I'm not sure that MassHealth is requiring that. It's interesting that they're having you sign that when they're not necessarily going to be selected to be an MCO. They don't exist yet. So I can have a conversation with you offline about that.
Okay, that looks like all the questions we have. So I want to thank Lydia and thank everyone for attending today's webinar. Again, once you leave today's webinar, you'll receive an email, and it will also have a link to a survey. And we appreciate any feedback you can provide us on this presentation. Based on that feedback, and as things develop, we will be holding additional webinars that we will keep you updated on. And on behalf of ABH, one more time, I want to thank you for joining us and hope you enjoy the rest of this beautiful sunny day. Thank you.
Thank you.